Thank you, chairpersons, for kind introduction. Thank you, Dr. Isar Arvind, Dr. Shashank Joshi, Bansi, Manoj, and Amit, and Dr. Sanjeev Phatak for making me part of this prestigious event, that is World Congress on Diabetes by Diabetes India 2025. So I will be talking about practical perspectives on early insulinization with gold standard basal insulin. So we all know this data, the landmark trial, where more than 6,000 patients they were studied, and it was the first large-scale longitudinal prospective observational real-world study to investigate management and complications in type 2 diabetes across India, and that was over a period of 3 years. What this study concluded? That 1 in 5 patients, they are only under control as far as HbA1c less than 7 is concerned. Average diabetes patient is either obese or overweight. Average BMI was around 27.2. 18% patients, they have macro or microvascular complications, and 5 times higher risk of complications in overweight patients. At the same time, they also given an insight about the multiple oral anti-diabetic agents, how they are behaving as far as glucose control is concerned in our Indian population. So the patients who were on less than 3 OADs and the patients who were on more than 3 OADs, so 4 or 5 OADs and 3 OADs, these two groups, there was not much difference in glucose control. So the patients who are on optimal dose of 3 OADs, and if they are having HbA1c more than 0.5% above target, if you put them on a 4th OAD or 5th OAD, the chances of reaching target are minuscule. So this is the time when you should think of insulin as an option to reach glycemic targets in this type 2 diabetic patients. 1 in 4 Indians with established type 2 diabetes, they take insulin. This was as baseline, and 9.2% average HbA1c at which insulin is initiated. So this is very high. I think 8, if it was around 8, then also it is fair, but 9.2 is the average HbA1c with 3 or more drugs, and we are starting insulin. So we are wasting lot of time before initiating insulin in deserving patients with type 2 diabetes. So timely step up of therapy from OAD to insulin is very much required currently in our setup in our country for good glycemic control. So let's take a look at this hypothetical garden variety case. Mr. Alok is 52-year-old. He is having 78 kg body weight. He is diabetic since 7 years and is grocery shop owner. So he is having a peculiar lifestyle. We all know the people who are there having shop owners, their peculiar lifestyle. His clinical parameters currently are HbA1c 9.2, fasting of 194 and post meal of 256, and blood pressure is 142/84. Currently he is on glimepiride 4 mg, metformin 1000 mg twice daily, and dapagliflozin 10 mg OD. So this is a patient who is on 3 drugs, optimal dose oral anti-diabetic agents, and is still having HbA1c of 9.2, is overweight, and is also having comorbidity of hypertension. So this patient is at risk of developing complications. We need to reduce HbA1c to below 7%. If we can bring it to at least less than 7.5, that will also be helpful for this patient. And we all agree that adding 1 or more agents at this level of HbA1c of 9.2 will not make him reach the target HbA1c. Even if the target is 7.5, he will not be able to reach. So this patient definitely requires insulin. Is there any evidence for the glargine or the basal insulin, whether it is useful in this category of patients? That we will see in the subsequent slides. So we know that nowadays in type 2 diabetic patients who are not reaching targets with optimal dose of 3 or more oral anti-diabetic agents, basal insulin is recommended by almost all the organizations across the globe with the concept of fix fasting first. So most of these patients, they are having elevated fasting hyperglycemia, and because of that, if the fasting is 190, PP is going to rise from that. So PP is always going to remain high. If you can bring that fasting from 190 to 110, the most of the time the PP will also come within the range of less than 180. So this is the concept of fixed fasting first. So if you use basal insulin, you can take care of this elevated fasting hyperglycemia. You can bring fasting to the normal range, and that will bring also all post meal sugars within the range, and the patient will reach target HbA1c of less than 7 or less than 7.5 in most of the cases. So glargine 100 is the basal insulin which provides mealtime flexibility. One injection per day, it should be taken same time every day. So whenever you write a glargine prescription, you have to mention time. It is not bedtime, it is not before dinner, after dinner. It is to be taken same time every day. That is what the message should be conveyed to the patient. It can be injected any time of the day, morning, afternoon, evening, night. It gives you a 24-hour half-life. So 1 prick a day, very easy to start. 0.2 units per kg body weight per day. You have to start this dose. Very easy to titrate. Every third day, you measure fasting plasma glucose. Average of 3 days fasting plasma glucose. You give them a target of 90 to 120 or 100 to 130 depending on the patient profile, and they can increase the dose by 2 units or decrease the dose by 2 units depending on that fasting plasma glucose. So very easy to start, very easy to titrate, and very easy to inculcate in routine lifestyle of a patient. They can take any time but same time every day. What is the evidence? Because we know that our country is a country where a lot of premix insulin is being used for initiation, for intensification, and for insulin therapy in type 2 diabetic patients. In tier 2, tier 3 cities, still premix insulin is used by many of the primary care physicians. And I think now it is high time that the first thing to start in type 2 diabetes should be basal insulin. There is enough evidence. If you see here, the HbA1c you can reduce with any kind of insulin. It is the hypoglycemia which matters, and where the basal insulin fares much better as compared to the premix insulin. The fasting, postprandial, HbA1c all are decreased. PP will be decreased more with the help of premix because they contain a bolus insulin component, and the HbA1c reduction is almost similar. So this in landmark trial over a period of 3 years, whether the patient was on basal insulin or on premix insulin, the glycemic parameters were similar even after 3 years in the basal insulin group versus human premix insulin group. But the people who were on premix, they were having high risk of hypoglycemia. This is another data from our country, Live India, effectiveness of glargine 100 in a post-hoc pooled analysis of Fine Asia and Gold registries. To assess the change in HbA1c from baseline to 6 months, 955 patients, mean age of 54.7, mean BMI of 27.4, comorbidities in the form of hypertension and dyslipidemia in almost 3/4 of patients. HbA1c baseline is 9.54 and fasting at baseline is 215.5. The second primary objective was HbA1c reduction, and secondary objective was change in fasting plasma glucose, body weight, insulin dose, and the incidence of hypoglycemia. If you see, the HbA1c was reduced from 9.54 to 8.2 at the end of 3 months and 7.5 at the end of 6 months. 1/3 of patients were able to reach HbA1c target less than 7, and 2/3 of patients they were able to reach HbA1c target of less than 7.5 with just 1 prick of insulin glargine at once a day at same time every day. If we see the change in body weight, there was no weight gain observed with glargine, only 100 gram difference in the kg. And the glargine dose, if you start properly, that is 0.2 units per kg body weight per day, you require a very low titration. Most of the patients over a period of 3 to 4 weeks, they will reach that target fasting plasma glucose. And the change required over a period of 6 months in this study was only 2.5 units. And that was able to reach that fasting plasma glucose target and HbA1c below 7 in 30% of patients and less than 7.5 in almost 60% of patients. if we see the hypoglycemia, the glargine insulin fares much better as compared to any kind of premix insulin, whether it is a human premix or it is a premix insulin analog like BiSP30 or a co-formulation like IDEC-ESP. So here all the three aspects, if you see, there is a much less overall hypoglycemia, nocturnal hypoglycemia, confirmed hypoglycemia with basal insulin as compared to either human premix or premix analog or co-formulation. Weight gain is also lower if you see with as compared to premix insulin by F30, 35% less weight gain with glargine alone, and compared to co-formulation 36% less gain with glargine, and also the insulin dose requirement is also much less. Here it is 33% less and here it is 11% less. If you see, these are the Western studies, so the dose of glargine which is required in these studies is around 50 to 60 as compared to 20 and 30 units which are required in Indian studies. The persistence will be better because patient has to take only one prick. It has nothing to do with meal. They can take any time of the day, same time every day. You can give at 10 p.m., 11 p.m., whatever is convenient to the patient. They don't interfere with their daily schedule, their meal schedule. So they persist better if you start them on a basal insulin once daily, that is innovator glargine 100, as compared to if you start them on a premix insulin, the persistence rate are much less. And the landmark trial had also again given you a hint that even if you give glargine with OADs, you are able to maintain HbA1c in the range for a period of 2 years, and the dose requirement is around 20 to 25 units. So this is our own Indian data supporting the durability of once daily glargine 100 along with OADs, providing sustained glucose control over a period of 2 years. We all know that now we all are bombarded with a variety of biosimilars related to glargine. But one thing you have to keep in mind that currently the innovator glargine 100 is priced same like any biosimilar which is available in the market. And I will say that the innovator glargine has got the best evidence so far, so it is to be used preferentially in type 2 diabetic patients. Whenever you think of a basal insulin, you should think of a glargine 100 by an innovator because it has got all the evidence and it is available at the same rate like all other biosimilars. And biosimilars might be having immunogenicity. There is data to support that. Some of the biosimilars have got increased interleukin production. There were some slides, I think they are not getting popped up here, but you have to keep in mind that if all are available at the same rate, you have to prefer the innovator which has got evidence, which has got efficacy and safety data that is to be used in type 2 diabetic patients. So this patient requires insulin. If you give them a insulin 10 units and you do no titration, then this is not the way. This is suboptimal insulin therapy. Patient will never reach target. If you give them proper dose, that is 2 units per kg body weight, here the weight is 80, so 16 units, and you do no titration, then again it is a suboptimal insulin therapy and patient will not reach target. You have to start the proper dose and you have to counsel about titration every 3 to 5 days so that they can reach target fasting plasma glucose and they can reach the target HbA1c within a period of 3 to 6 months, and that is the way you have to use innovator glargine 100 in your type 2 diabetic patients who are not able to reach control with 3 OADs in an optimal dose. So key to achieving optimal glycemic control is timely insulin initiation along with adequate titration, and intensification is required. Suppose this patient has reached target fasting plasma glucose of 110 and HbA1c is still 7.7, 7.8, 7.9. What will you do? Now you have got two options. One option is basal plus. You can add 1 prick of glulysin with major meal and many of your patients will reach that target of less than 7. And the second option is again available where you can combine the co-formulation is available where glargine is combined with a GLP-1 lixisenatide. You can shift your patients from basal glargine 100 to that combination, and they will be able to reach the target. So now you've got two options to intensify when your patient is on an innovator glargine 100. So this is basal plus versus premix therapy, that is one glargine plus one glulicine. If we see the evidence efficacy wise, as compared to premix regime, both are having same glucose control. These are various data to support. If we see safety, less hypoglycemia is there because it is much more physiological and according to the meals of the patient. Flexibility, basal plus will be much more flexible because it will be taking care of both fasting and prandial components, and it is a physiological. It will cover one meal, major meal, and will provide better glucose control with that meal, and that way you will be able to reach target in many number of patients who are not reaching target with one peak of glargine 100. And this is much more physiological, much more flexible, and much more acceptable to the patients. So patient satisfaction is also better with basal plus, which is flexible. Patients can adjust the dose as compared to premix, where dose adjustment is a bit tricky and the risk of hypoglycemia is more. There are proof of concept studies like Opel, Owens study done by Professor Owens, Illionaire, and Start. All these studies, they have concluded that if you use basal plus regime, you will be able to reach HbA1c from baseline of 7.3 to 7.4 to 6.9 and 7. Almost many number of patients, if they are failing on glargine, almost 50%, 30 to 40% of those patients, you give one prick and they will be able to reach target. Improvements in HbA1c with marked improvement in treatment satisfaction, and this overall, the basal plus regime was very effective in improving HbA1c. So I will conclude by saying that patients on 3 drugs, optimal dose, HbA1c above 0.5% above the target, think of insulin. Always fix fasting first with basal insulin. Whenever you think of basal insulin, think of innovator glargine 100. Start with right dose, do proper titration, reach the fasting target. You will be able to reach HbA1c of less than 7 in 1/3 of patients, less than 7.5 in 60% of patients. If required, give one peak of bolus or shift patients from one peak of innovator glargine 100 to a co-formulation of glargine with GLP-1, and then you will be able to reach target in many number of your patients without increasing the risk of hypoglycemia. So basal insulin is recommended as the most convenient initial insulin regime. Glargine with OADs can help your patients reach target and maintain target for a period of more than 2 years as per the landmark data. And basal plus approach is a better way to intensify therapy rather than shifting to premix. Basal plus will give better flexibility, lower hypoglycemia, and more physiological way of insulin replacement whenever you think of intensification after basal insulin therapy. Thank you very much.